So good afternoon everyone. So I'm Dr. Isha from Department of Pathology. So today's our topic is on emphysema, which is a competency for you. It is PA to 25.6. So the objectives of today's competency is, first we should be able to, by the end of the PPT, we should be able to define what is emphysema, what are the types of emphysema, and what are the pathophysiological mechanism behind the emphysema, and also the gross and the microscopic findings in emphysema, and we will have a very brief discussion about the clinical presentation of emphysema. So we know, so before going into emphysema, we will have a very short description about what is the disorders, lung disorders. We can classify them into obstructive lung disorders as well as restrictive. So in obstructive, there is increase in the resistance to the airflow, which may be due to partial or complete obstruction to the airflow. So that is obstructive lung disorders, and we have restrictive group where there is reduced expansion of the lung parenchyma with decreased lung capacity. So how do we classify these into obstructive and restrictive is based on the pulmonary function test. So when you do a pulmonary function test, the FEV1, that is forced expiratory volume by forced vital capacity, you get a value less than 0.5 in the obstructive kind of disease, whereas when you do FEV1 by FEC, we get a normal value because there is a proportionate decrease in both FEV1 as well as the forced vital capacity. That is why we get a normal ratio. So now we have the obstructive lung disorders. So these are some of the obstructive lung disorders. We have emphysema, chronic bronchitis, the bronchial asthma and bronchitis. So we have grouped has been grouped, emphysema and chronic bronchitis has been grouped into a category called as COPD, which stands for chronic obstructive pulmonary lung disease. So according to WHO, it's a common, preventable as well as a treatable disease. So when you characterize, and it is characterized by presence of persistent symptoms of respiratory like wheezing, breathlessness, cough with expectoration, due to it could be a airway or an alveolar abnormality, and it can be due to exposure to noxious as well as any particles or gas which can irritate the lung, leading to the pathology. So today is our topic. Now coming to our main topic, that is emphysema. So emphysema, it's a irreversible enlargement or dilatation of the air spaces which are distal to the terminal bronchiole, and as well as there is accompanied destruction of the alveolar wall. So for the easy understanding, you can keep in mind there are 3 Ds. One is the distal, dilatation as well as the destruction. So remember, it is distal arterioles are damaged where there is destruction as well as there is dilatation. So we can classify emphysema based upon the anatomical location. So first one, as you can see here, that is centri-acinar emphysema, where the obstruction is on the respiratory arteriole. So before that, I should have discussed on this. This is the normal SNS, where you can see a terminal bronchiole. After that, we have the respiratory bronchiole, which divides into alveolar ducts and ends as the alveoli. So centri-acinar emphysema is where you have the emphysematous change involving the respiratory bronchiole. When the whole of the respiratory bronchiole is involved along with the alveolar duct and alveoli is involved, we call it as pan-acinar emphysema. Then we have 2 more, the paraseptal as well as the irregular. So in paraseptal, we have the alveolus as well as the alveolar ducts are involved, and in irregular we have the there will be involvement of both centri-acinar, paraseptal, but along with there will be a fibrotic change in the lung. So now we will discuss in detail about the centri-acinar type. So this is the most common form among all these 4. So this predominantly occurs in the heavy smokers, and it has a predilection to be involving the upper lobes, predominantly the apical segment. So in this emphysematus, we have both emphysematus as well as the normal air spaces can coexist within the same SNS as well as the lobule. Next we have the pan-acinar. So pan-acinar is associated with alpha-1 antitrypsin deficiency. We will go to, when you go to the pathogenesis, we will understand what is alpha-1 antitrypsin deficiency and what it does to the lung. So this paraseptal can be exacerbated by smoking, and this predominantly involves the lower zones of the lung. Now the paraseptal the emphysema is more strikingly near to the pleura as well as at the margins of the lobule. So, this occurs predominantly adjacent to the areas where you have fibrosis, scarring or atelectasis. This is the area where you have a paraseptal kind of emphysematous change. Now finally the last one, that is the irregular emphysema, where you have air spaces enlargement along with fibrosis, but this has a very little clinical significance because most of the time they are very small foci of enlargement can only be seen. So now coming to the pathogenesis. So before going to pathogenesis, we should know a little bit of what is elastin. So elastin is an extracellular component of our lung matrix. So this is actually required to maintain the integrity of a lung parenchyma as well as our small airways. So there are certain substances which is called as proteases or elastases which are released by the neutrophils that can digest as well as destroy the parenchymal air spaces. So in any kind of inflammation or infection where the neutrophils come into play, they have a role where they can release the proteases or elastases and they will damage the lung parenchyma. So whenever there is inflammation, as I told before, there is inflammation which will call upon the neutrophils, and neutrophils will start releasing the proteases which can damage or digest. So there is an enzyme which is called as alpha 1 antitrypsin which inhibit these proteases and it has a protective effect on the lung. So what happens if alpha 1 antitrypsin is deficient in our body? What happens? The damage will go on, which is leading to digestion of the elastic tissue and leading to the emphysematous change in the lung. Now this is, so one of the important cause for the emphysema is the chronic smoking as well as the one congenital is the alpha 1 antitrypsin deficiency. So how these predispose to emphysema is, the tobacco they can release the reactive oxygen species. So they will inactivate the antiprotease leading to increase in the neutrophil elastase leading to the emphysematous change. And also these tobacco smoking can recruit more neutrophils to the site of respiratory epithelium where they can damage by release of more and more of neutrophil elastase. And also the congenital alpha 1 trypsin deficiency where there is absence of alpha anti 1 trypsin will lead to increase in the elastase, and ultimately all this will cause alveolar damage. So same thing whichever I discussed, this is a more easy chart which is from the Robbins, the reference. So smoking, air pollutants along with the genetic predisposition can damage the lung in 3 ways: from the oxidative stress leading to apoptosis, or the inflammatory release from releasing the mediators, and finally the antiprotease imbalance ultimately leading to the alveolar wall destruction. So now, we saw that airways are dilated. So why there is an obstruction and why it is leading to COPD. So destruction of the elastic tissues in the walls of the alveoli surrounding the respiratory bronchiole, they reduces, whenever they damage, what is happening? There is reduce in the traction. So which will collapse the respiratory bronchioles during expiration and which will lead to functional airway obstruction. So to remember what is the function of the elastic tissue, it has the property to recoil the lung tissue and it will keep the small airways patent. So when the elastic tissue is damaged, what happens? This recoil is lost and it will lead to functional airway obstruction. So coming to the morphological part, in pathology we are very concerned about morphology, the gross as well as the pathological, the microscopic finding. So when you get a gross specimen, you have a voluminous lung with, if you get a cut section, you can see large alveolus can be easily seen on a fixed tissue, and also there is something called as apical bleps or bullae which is characteristic of the paraseptal or the irregular type of emphysema. You can see bullaes. That is nothing but the thinned out lung give an appearance of a bullae. So these bullaes are very important because once they ruptures into, they can produce a spontaneous pneumothorax. That is one of the complications of the emphysema. So these images are from the Harshmohan textbook of pathology. So you can see here the bullaes, and that is a gross representation. So you can see here on the B diagram there is a bullae. So this is the microscopic image where you can see, so the dilated space, those are the dilated alveolar spaces, and some places as the alveoli enlarges they can be broken and they can be stretched out, leading to distended alveoli and alveolar duct, and you can also see spurs of broken septae. So, these are the classical finding where you have a dilated septae with broken alveoli can also be seen. Okay. So, finally, we will see what are the clinical features. So, 1/3 of the parenchyma should be involved for the emphysema to show a clinical manifestation. Most of the time the patients with emphysema present with a progressive dyspnea, and also they can have cough and wheezing, and they can also present with weight loss because of the chronic inflammation and the energy required to expire the air. It can lead to the weight loss, and they have a barrel chest appearance on physical examination. They are also called as pink puffers because during expiration the expiration is done with the pursed lips, and that is done mainly to increase the increase the airway pressure and to prevent the airway from collapsing during the expiration. So, they are called as, remember that is a very important question, it is called as pink puffers. So, the complication which can occur as a part of emphysema is pneumothorax. It can lead to pulmonary hypertension and also the right heart failure. So, finally, the summary. So, what is emphysema? It is a irreversible dilatation of air spaces which are distal to, and there is also destruction. So, remember the 3 Ds, there is dilatation which is distal as well as destruction is there. So, there are 3 types: centriacinar, panacinar, paraseptal as well as irregular, and the pathogenesis is mainly chronic inflammation, smoking, as well as the most important one is the alpha 1 antitrypsin deficiency. And clinically, morphologically, they can have a voluminous lung. In microscopy you can see dilated air spaces, alveoli with broken alveolar septa, and clinical finding. So, like they can present with a progressive dyspnea, and they are also called as pink puffers, and the complication as I mentioned, it can lead to right heart failure, pneumothorax, spontaneous pneumothorax and pulmonary hypertension. Thank you.